Well, good afternoon, everybody. I want to welcome you to the Art of Letting Grow, the Health Transition Pediatric to Adult Care webinar. Today, our presenter is Christy Blakely, and she's the former Executive Director of Family Voices Colorado. I'm your host. My name is Glenda Robertson, and I'm the Instructional Designer for Colorado Access. Today, we have several objectives that we hope to help you meet in this webinar. 4 things that you'll learn from this webinar are the ability to identify important developmental considerations of adolescent patients as they begin to transition out of a pediatric practice into an adult practice, locate resources related to health transitions, guardianship, and Social Security, utilize tools and resources to encourage adolescent patients to take more responsibility for their health care as they transition through the healthcare system, and to utilize tools and resources to support families of transitioning adolescent patients. Next, I want to go over some participation guidelines. First of all, everyone on this webinar is muted. That way we don't accidentally hear typing or people coming into your office. So therefore, if you need to chat with us or have questions, please use the chat window. Don't be alarmed if you don't see a lot of activity in the chat window, because you'll only see your own questions and responses. And we also won't be using the raised hand feature as well. Throughout the webinar, we'll have opportunities to stop and ask questions to Christy. I will be gathering the majority of them and giving them to her to respond to. And at the end of the webinar, we will be developing a frequently asked questions document, which we will distribute to answer all the other questions that we did not have time to get to. At the end of this webinar, we have a short evaluation. We would appreciate your feedback on this webinar. And a recording of today's presentation will be put on our RICO website, the Virtual Community for Collaborative Care, or VC3. With that, I'm going to turn the webinar over to Christy. Christy, it's all yours.
Good afternoon. We've also muted you so that we don't hear you chewing, since this is lunch for many. This module was funded by Colorado Access and in collaboration with Family Voices Colorado. And it's the first for the providers working with transition-age youth in their practices. So whether you're a provider or case manager, whatever your role, we titled this The Art of Letting Grow because that's a lot of what needs to happen at this time for kiddos. And families need to hear it's okay to let go. It is okay for the kiddo to begin to grow up and out. We have done 2 previous webinars or modules for parents on this same topic, and they're available on the Colorado Access, the VC3, as Glenda just mentioned. My name is Christy Blakely, and among other things, I'm the proud parent of 2 daughters, both in their 30s now. One has special needs and has taught me how to let go, and letting go was way, way harder than anything else in her life, which gives me some experience. Then they're both in significant relationships and living independently. There's going to be a considerable conversation throughout this whole thing. So I'm going to get started and hopefully not talk too fast. We are going to learn in this module today that letting go is part of life. We're going to learn that when we talk about creating independence, we're really talking about the ability that they can, as much as possible, their ability to become independent, and give some ideas and tools about ways to be creative about that. We're going to teach the youth or talk about letting the youth ask questions, and of course I'm going to give some suggestions on provider transition policies. We're going to talk about that a little bit later. We're going to learn about tools, resources for families that you may not know about, learning about agencies that support this transitional age throughout Colorado, and Encourage families to get organized with some documentation. There are resources to help providers, and there are different ages and stages to create transitions. So let's get started and see where we go. There are many transitions through a family's life or a child's life, and those transitions can be very challenging, especially if a child has special health care need. The transitions will continue to happen, but what it does is create an interruption in the services. It also creates oftentimes different agencies to be involved or service providers to be involved. Rules and paperwork, all of that creates discomfort or discourse in the family. So understanding that transition is one more kind of transition or change that the family isn't necessarily looking forward to, and helping them to be as clear and concise about how to do that transition as possible. Understanding that oftentimes in the transition age, some of the funding changes because of the age and stage. We're going to get into that, the age 18 and all of those changes. But even where the service is provided. So it happens throughout, and so it's one of the reasons families get very angst about transition. What happens? What happens at 18? What happens at 21? How do I know what all is going to happen? Here are some recommendations. Be clear, concise, and anticipate that families are really going to be asking, is there a transition policy? Things you may wish to consider in transition policies, things like if you're a pediatric practice, a young woman becoming pregnant, she would then automatically become a part of the adult care, these are the things that you have to decide as a office, as an organization. If kiddos go off to college, changing providers may not make a whole lot of sense until they're graduated or settled. If they're going into a job, that may be a good transition time for them. Looking at the length of your waiting list. If your waiting list is incredibly long, you may want to think about making a shorter or sooner transition, so going at 17, 18. If there's other specialty care involved, adult providers in the area, be aware that EPSDT, or Early Periodic Screening, Diagnosis, and Treatment, the Children's Benefit Package for Medicaid, doesn't end until the 21st birthday. But thinking about some natural transitions and when kids should move out to an adult care, there are more components that need to be looked at, and your office needs to make those decisions and then be very clear and concise about it with families so that they can anticipate, oh, I understand this, rather than the surprise of, well, the neurologist transitions people at 16, so I go to an adult care for neurology, but I stay with the pediatrician until I'm, 26. It gets a little crazy. So helping families is a good way to think about it. Also, if you're in a managed care, your case managers, like Colorado Access, will help you create that plan if you're in their network. There are many transitions families and children with special needs especially must navigate as they turn 14, 16, 18, and 21. There are different service systems which families must learn. Many of these systems we will be talking about at the parental income prior to 18, but after 18 they're not looking at the family's income, they're looking at the individual's income. One transition not looked at, not really talked about, is health care as children become adults, and that's the purpose of this presentation. Beginning at age 14, career goals begin to be added to the IEP, or Individual Education Plan, in the school system, and they're required by the Individuals with Disability Education Act, or IDEA. If families are asking health providers about school issues, you might want to refer them to your county ARC or to Parent Center in Colorado Springs, which is our parent training entity in Colorado Springs. Don't panic if I'm going to have resources at the end of the whole slide presentation, so you'll be able to get some of these in the websites, etc. If you feel overwhelmed by looking at this slide, that's just a little of what families feel as they move through this system. Another recommendation that I want to make and encourage is that beginning as young as you can or feel comfortable with, even as early as 10 or earlier, that kiddos begin to ask one healthcare question per visit. Learning to take a role in their health is a first step to understanding its importance, and as families can model good healthcare behaviors by being on time and having questions written down, talking ahead of time. Gee, is there anything that you want to ask while we're in the doctor today? If the child begins to interact with the provider, there's a greater comfort, and as they grow into adults, they can better communicate with providers. Studies are indicating, and I've given the list in a footer, that we are really seeing the least amount of activity and transition for families of low income and minorities. That may not be a surprise to some of you across the state of Colorado, but it's really a need that we encourage the kiddo to start asking the questions themselves, if at all possible. So here are the way school services have listed things out with special language for readiness into adult life. They talk, in healthcare, we're a little behind. We don't really have this kind of planning that goes along with transition. There are other factors around large number of kids living in the community, young people living longer with or without special needs. There are studies called a SLAIT study, SLAITS. It stands for the State and Local Area Integrated Telephone Survey. But they ask questions, data questions about transition and families. And it was funded through the Centers for Disease Control and HRSA. But it really identifies that transition is a huge goal, and there's many people working on it, but we really don't have a solid understanding of how to concretely move kids to the next level. I'm encouraging us to think about the healthcare transition not as the void that O'Connor mentions in one of her articles under the CDC, but that we really talk about what is working. There's been success with the disease-specific populations, groups working with models where the components are very finite. It's a special set of circumstances or a special set of specialists. These populations that struggle the most are the more complex, that have more moving parts or more specialists involved. This may not be rocket science for you all, but there is no constant, and that's what's so difficult. Some of the financial disincentives for providers to take kids after age 18 had to do with Medicaid only as their funder, and some of that's gone away with the Affordable Care Act and the possibility for families to carry their kids' insurance until they're 26. But we still have a medical void as far as how do we transition? What are the steps to transitioning? And what the National Center tells us, and there's a National Center for Transition called Got Transition. I'm going to give you that website later. They really are talking about planning ahead. But as a provider, I would be hearing them and talking about, well, how do I fund that planning stage? So that is yet to be discovered. Creating independence takes time, and it's an ongoing process. I think of it as a sprint, not as a relay race. Not as a sprint, but a relay race. Begin to share the things such as food allergies, body awareness. Talk out loud. Encourage families to talk out loud with their kiddo about, you drank 3 soda pops after dinner. How'd you sleep? Talking about themselves and how they can do a better job of asking those health questions. and really having the parents listen, so that if somebody says, tell me about, you, and the kiddo says, well, I sometimes can't fall asleep, let the parent be quiet and let the child describe what's going on. It not only informs the parent, but it also lets the parent know whether the kid really does have a handle on their health care and what's going on. We also want to encourage families to explain to kids their insurance and why it's important and what they should have. I encourage families as young as 10 to 14, put copies of the insurance cards in the backpack and say, you're not going to need this unless it's an emergency, but it's important for us to have it. See, Mom keeps it in her purse, Dad keeps it in his wallet. One of the big questions that's often on the tip of everybody's tongue is, how do I find those adult providers? The state Medicaid or our Healthy Communities people do have lists of doctors. Your entities such as Colorado Access do have lists of providers that are in the area. But identifying the specialists in the practices and understanding when they're transitioning that you refer to a lot may help you in developing those transition plans or policies for yourself. Begin with providers to talk about your insurance and how that impacts who you can go to, but finding out and then encouraging families to call the provider and talk to them about the kiddo or the needs, making sure that everybody has that communication. In the Wall Street Journal, there was an article that talks about young people that they fall in this medical void. They leave the pediatrician's office, but they don't go and find a primary care. Not sure whether Melinda Beck in this article was really taking into consideration that there are now networks that encourage that and follow up with kiddos. But it is writing that informs us that this is a continued focus. So some of the articles and information being provided by GOT Transition, which is the Center for Excellence under HRSA, in collaboration with Academy of Peds, et cetera. There's committees working on how do we transition. In Colorado, our Title V, or we call it HCP, it stands for Healthcare Program for Children with Special Needs. They have a goal or an outcome around transition as well. And they're located in your health departments and funded by Maternal Child Health. All of these entities are really talking about what is transition and how do we do transition. In GOT Transition, they have 6 core elements: the policy, the registry, preparation, planning, transfer of care, and the completion. But it all starts from the policy, and so that's really where I encourage providers to say, we've got to have a policy. Let's talk about what that policy looks like and what we're comfortable with. Okay, I'd love to tell you that this is a picture of me, but it's not. But anyway, I am ready to take questions. So, Glenda, would you like to give me the first questions today?
Sure. Actually, none have come in so far. So if you have a question for Christy at this point, go ahead and type it in your chat window. I will see it and feed it on to Christy. So we'll give them just a few minutes as not to have a lot of dead air space. And it sounds like the information that you're providing is right on everyone's radar, that they are getting it. So, so far no questions. So if you have questions, again, don't hesitate to put them in the chat. I will flag them for our next question break, and then Christy will be happy to answer them. So Christy, it's back to you.
Okie doke. So I'm excited to share that there's a transition wheel now. Children don't come with guidebooks or roadmaps, and it's one of the things I've heard over the years that I've worked with families, the question of how am I supposed to know when to do what and how. And so Family Voices put this transition wheel or guide to transition together to hopefully help families understand some ideas about what they can be doing. This tool is a two-sided deal, so I've showed you both sides in this slide, and it's broken out in the areas of life skills and family and school, and then on the other side, career and health. Let's look at this tool just a little bit closer. There are ages and stages that the window turns to. So the ages and stages, like for education, we've used the health awareness, so awareness from age 10 to 14, exploration from 15 to 17. So at health awareness, 10 to 14, we're going to be aware of appointments and services, care needs and medications, and really become aware of what the needs are, whether it's asthma and always having an inhaler, or whether it's diabetes and watching what you eat, whether it's nothing and just being a healthy, typical kiddo that's involved in athletics or something like that, being aware of yourself and how appointments are made. I encourage families to start with things like practicing making your own hair appointment if the doctor appointment is too scary. From 15 to 17, we look at exploration, a time to ask your provider about their transition policy, develop the portal for medical records if you don't already have one. But getting that health medical background is kind of an important component. We're really focused on immunizations early in a child's life, but where does that immunization card or information go so that the child has it as they become adults and know, yes, you did have chicken pox, or no, you didn't. All of those kinds of things should be written down, or information should be available somewhere. So encouraging those families to have those conversations, as well as insurance coverage and how that works. Don't worry, there's overlapping activities, because a lot of teens aren't interested, and that's really why we started at the age of 10 to 14, because the data shows that kiddos tend to check out or not be learning as much around 15 to 18 to 21, and then they kind of kick back in again. So that's why the length of time. At 18, we're talking about health preparation for adulthood. So we're talking about, at 18, the possibility of supplemental security income if the child's disabled, or that insurance may change, that there's school responsibilities. But at the age of 18, that kiddo is no longer the responsibility of the family financially. So the ability for so what happens is the family's income is no longer looked at regarding programs, etc. So the emancipated is that legal term. From 19 to 21, we're really talking about education and training. We're really hoping that we can start to practice with them some of the things that good health activities, running, walking, an exercise program, good choices with food, etc. Then finally, from 22 to 26 is a time for settling into that career. But for some of our kids with more significant disabilities, just working on transportation or housing, community access may be lifetime goals. So the timelines aren't written in stone. It's more a focus of what should we be doing and what are we developmentally ready for. Oops. Sorry, people. This is kind of a close-up of the wheel. Easy to follow suggestions under each of the areas for each age and stage. So you're looking at the 10 to 14-year-old awareness, and then you can see on the left there's ABC School, and it's in red. That's the top. Then the black is the career planning, and the red below is the healthcare coverage, and what we can be doing at those ages and stages. There are also resources, information, and reminders on the front of the transition wheel. And it's also broken down and you can see that there's a little hook. You can hook it on the refrigerator and only focus on the time and the age right now. So families don't have to be overwhelmed with all 10 to 26 years, but just those years that are critical to the right now. Everything's color-coded, as we kind of pointed out. And there's an information contact for Family Voices. The tools can be ordered from the Family Voices Colorado website, and again, resources at the end of the PowerPoint. They're $5 per wheel, or a reduction if you order larger quantities. So from 15 to 17, youth can learn to refill prescriptions independently via some of the websites for some of our pharmaceuticals, et cetera, and scheduling appointments. They can become better able to do that under the coaching or guidance of family, and that way they're better able to do it as they get out and are more independent. Now, providers' ages and stages knowledge, here's where we're going to get into some of the really good stuff. Healthcare coverage is more complex than ever, and you all as providers are asked to do so much. And just the paperwork alone is overwhelming. But talk to your whole staff and have a plan. That policy is pretty important. And you may want to collaborate with local agencies to create a community one-page guide for families. Family Voices does have one up on their website, transition kind of page booklet. It's like a 4-page booklet. Many of the resources that we're talking about today provide trainings, like the Guardianship Alliance. They provide transition services. And you may want to invite one of these agencies into your office to do some work with families. So we've got Medicaid versus private insurance. Families often want to get on Medicaid. I hear that a lot. I just want Medicaid. And it didn't used to be that way, but today is a different day. So what we need to be asking families when they say this to us, what are you hoping to gain? What is it that you don't have now that you're hoping to get through Medicaid? Because that will really make them not just want what they think they want, but better understand what isn't being covered under the services they're receiving now. What we know is that a child may be on Medicaid due to financial eligibility of the family, but there are other ways to access Medicaid in today's world. It is a better benefit package. For kiddos under the age of 21, there's no co-pays. And there's no balance billing. So if a child leaves, an expensive hospital stay and private insurance only covers a percentage, say 80%, that other 20% may still be a hefty sum. Under Medicaid, you don't have that balance billing. That makes a huge difference for families, especially families like mine. But Colorado has 4 primary children's waivers. One's the CES, Children's Extensive Support. It's administered by the DD, or Community Center Board System. There's the Children's Medical Waiver. Sometimes you'll hear it called Katie Beckett. Sometimes you'll hear it called Model 200. All are historic names. It's now the Children's Medical Waiver. And these are all home and community-based service waivers, or HCBS waivers. They're ways that Medicaid is being provided to kids with specific targeted population needs, healthcare needs. Another one of our waivers for children is the autism waiver, or the CWA, Children with Autism Waiver. And it's unique in the fact that it's from birth up to the age of 6. So a child would be no longer eligible for that waiver if they're over 6. And it's also looking for a medical diagnosis of autism. The CES waiver currently has a waiting list, but that waiting list is going down because of some funding from the last legislative session. The autism waiver does have a waiting list. The children's medical waiver does have a current waiting list. And there is a waiting list for the hospice or HOPE waiver. And they call it now the Children's Life Limiting waiver is what that one's called. I didn't correct that slide. I apologize, people. But Colorado also has a buy-in for Medicaid. Now, these waivers tend to end at age 18, and you may ask why, but it has to do with that piece of children are emancipated. So these waivers may or may not look at the income of the family, but not all of them do, but they end at 18 because then the child flips over to an adult waiver if there isn't a waiting list. When the buy-in came to be, and Medicaid has a buy-in for Medicaid, there's a sliding fee scale and premiums that are going to be charged. We've had that for about a year and a month or so. We encourage families to keep their private insurance, and the reason we do that is for two reasons. One, the reimbursement is better for providers. We know that it's more comprehensive care if we have both Medicaid and private insurance. We also know that their eligibility may change, and then they would not have insurance, so we like for them to keep it. There's actually a program called HIBI, Health Insurance Buy-In, through Medicaid that the family can be reimbursed for the child's premium costs. So just the child's premium costs, but in order for them to keep their private insurance while they have Medicaid. And that HIBI, Health Insurance Buy-In, you can go to the Healthcare Policy and Financing website and get that link to HIBI if you Google HIBI, which is up in the right-hand corner. So there's different ways to have both private insurance and Medicaid, and this is one of the things that is very complex because you need to kind of know how the family got into Medicaid in order to understand what their benefit package is. When I'm doing this presentation for families, I tend to talk about rooms in the house because if you go into the Children's Extensive Support Services waiver, you're in the Medicaid house, but you get to go into a special room for CES that has extra benefits. So it's the easiest way for families to kind of picture how this all looks. So what we have to understand is that Medicaid does equal medical need, and so most of these waivers are for kiddos with special health care needs, some type of special health care need. And they're all under this HCBS. Then there are adult waivers that after 18 we can go on to. The Supported Living Services waiver is also managed out of the Community Center Board. There's a mentally ill waiver. There's an elderly, blind, and disabled EBD waiver. There's a brain injury waiver. The Medicaid chart is at this very short link, and the thing to know is that Colorado does have the most waivers of any state, so it's pretty overwhelming for families to understand, and so just understand that this is all going on. For those of you that are treating kiddos that are in foster care, it's especially tricky because children in foster care should have Medicaid. If they don't, you need to communicate to Human Services. And then they are supposed to have Medicaid through the age of 21 through some legislation that was passed a number of years ago. However, if the child's adopted, they may not come with Medicaid. The family must ask for the adoption Medicaid benefit. So you may find kiddos that have been adopted that don't have Medicaid. Treating kids in foster care as you would any child in transition is even more important because we need to create their health history so they, as adults, will know the childhood diseases, the immunizations, the things that have happened in their lives. And when they leave the system, they should carry that with them. There isn't really a way for that to happen. So helping those families put together some sort of a history. And there are, again, resources on the Family Voices website, as well as I know that there's some on the Parent-to-Parent. There are also transition checklists, and I have those resources at the end of this presentation. For youth in foster care, understanding how to make appointments, speak to providers, and advocate for their own health is even more critical when they don't have necessarily an adult that's going to be with them in that forever kind of thought process. So making sure that they're learning to do those things is critical. So then over age 18, there are those additional waivers. We talked about those. And it's important to understand that after 18, the family's income isn't looked at. So when they're going into other programming, the family income is not as a critical component to whether they're going to qualify or not. When we talk about Medicaid and we talk about transition, we also need to think about any kind of need for home health or any kind of support services outside of a typical lifetime what's going on. So if the child has a disability or a long-term care need, they may be receiving home health. Medicaid calls this long-term care. And the family may not understand what happened, but somebody came to their home, they asked questions about feeding, dressing, and bathing, toileting, all those kinds of things as to their ability. The entity, if you have a child in your practice that you think should have some home health, the single entry point is where you start, and that link is at the bottom of this slide. But for kiddos, it's really hard to figure out who's eligible and what that is, because we're really talking about kids gaining the skill, not losing the skill. So you have to think about long-term care from that perspective of the adult who's had a stroke and has lost the skill, rather than hoping the child still gains the skill. And it's very confusing for families to know who to share what with, how much to tell strangers about what the youth is doing for themselves or not. And culturally, this is a hard thing. Some folks don't really feel comfortable talking about this, even with providers. So encouraging them to really talk about, how is the kiddo eating, and is there any special need while they're eating or dressing or bathing. But I encourage when a family comes to a provider to ask for home health or those kinds of services, I really encourage the family to keep a daily log, and for providers to think from the areas of asking, what do you do for this child that you didn't do for a typical child of the same age and stage? So if the family feels overwhelmed, you can hear that, listen to that, say, yes, I get that you're really overwhelmed, but what is it that you're doing for that child that is different than you did for your other kiddos, or that you would do for another 6 or 7-year-old? Because those are the points, that's where Medicaid would be tracking whether this child would qualify for home health. Private insurance does cover home health sometimes, but it tends to fall under custodial care, and you need to look at each individual's policy. In Medicaid also, there's a home health tool for evaluation that follows these aids of daily living, or ADLs, and it's called the ULTC 100.2, and it evaluates the care needs. So if a child is a baby, we expect to have to do a lot for that baby. If a child is 6 and we're still diapering them, that would be where the difference is in what you would do for the same age and stage. Okay, we're to questions. Do we have any at this point?
There is a question that came in. It's from Christine, and she was wondering if the transition
congratulations.
wheel. Yeah, she was wondering if the transition wheel is available in Spanish.
That is a great question, and I'd love to say yes. It is in the process of being translated as we speak. I talked to Tom Rose at Family Voices, and he shared with me that it is being translated. So the best thing to do is to go on the website and ask for them to send you one or send you information when they're available in Spanish. Great question.
Another one has come in from Maria, and she was wondering, can Medicaid cover bills for emergency visits out of state?
Ooh, say that again. I didn't quite understand the question.
Sure. It's can Medicaid cover bills for emergency visits out of state?
Yes, there's a prior authorization process, and the best way to do that is for the family to contact the Healthy Communities worker in their county. So if they're in Montezuma County, call the county health department and ask for the person in the Medicaid section. But if it's an emergency and they go to a hospital out of state, you obviously can't do a prior authorization, but you do it after the fact. So yes, I have seen that happen, yes.
And that's the end of our questions thus far, so let's continue on.
Oh, did somebody else come up?
Let's go ahead and keep on going, and we'll get to other questions next break.
Okie doke. Just keep picturing me like this lovely woman, because that's not how I look at all. Okay, so let's talk about this. One of the things that we are having to do with everyone, not just transitional age youth, but it's to really get a handle on health documentation and to understand whose responsibility is it. And it isn't just the doctor's responsibility. And that's something that families need to hear us say a lot, because it's not just in their hands, but to really be saying, I'm responsible to keep track of my medication chart. And so having a chart of some way to keep track of what your medication is a great way to then begin to take some ownership of the health that you're responsible for. Asking for copies of reports. And, you know, if the child has been hospitalized in procedures, I basically put together a document, like a Word document, that just has the ages of my child and what happened in those years, because it was the easiest way for me to kind of historically put together some sort of a documentation. But encouraging families to do that so there's some sort of a file ready to be handed off to the kid for transition is critical and a great way of them becoming more responsible. It's also a great way, especially if there's like behavior needs, that you can work with the provider office and the school to create those behavior action plans. So again, it's concrete, it's transparent, everybody knows that 3 strikes you're out, but these are what happens for the strikes, or here's the things that we're going to do. So everybody's kind of in it and understands it. It's not just the doctor. Here are some good questions, great question starters to begin with youth, and I use them as springboards to connect with youth and build their, build the relationship. And I don't hesitate to ask some of the hard questions. It's also, for those of you in practices, a great way through educating the youth in transition to really talk about emergency room utilization. Saying things like, do you have a special health care need? If you do, tell me about it. And at what age do you think you should go to adult care? So that get a sense of where they are. And one of the questions, where do you plan to live in 1, 3, and 5 years? Obviously, I wouldn't ask a 10-year-old that, but I would ask a 16-year-old that, just to get a sense of, have they even thought there? Have they even gone there with their brain? And what are their goals? What do they hope to do? What do you hope to be when you grow up? Is a question I often ask a kiddo that I meet. And then I also point out that most of the adults in the room also don't know what they want to be when they grow up. Feeling okay to talk to the doctor, but also telling them about medications. And do you know why you take those medications? Describe an emergency and when you'd go to the hospital and when you wouldn't. Being able to communicate some of these very basic things are the first steps to transition for youth. It is the first steps for them to take ownership and understand they must talk and tell you or communicate rather than it always being the parent communicating for them. And if there are other systems and you're not sure what other systems they're in, asking them, do you get any services from anybody else? Because you may find out some things as a provider that you didn't know, and yet you were filling out paperwork for those other organizations. But things like schools and community center boards, that isn't something you have to understand all about. There's all sorts of agencies out there that do that information, but being aware that it's okay to ask the questions even if you don't have the answers is a really critical part to, how are things going in school? Oh, I was just on a webinar and I heard about some resources. Have you tried Peak Parent Center? Have you tried your ARC? Those are the things that are best to do with families if you don't have the answers. Medication management is one way, tangible way, to begin that self-responsibility. And I did it. My daughter is very disabled. She is nonverbal, uses a communication device. But I made color copies of the pills she was to take at each time of day. And I had her match those pills so that she was able to say, yes, they're all there, or no, they're not all there. So the task can be broken down so that you can figure out what are they capable of. Are they capable of just saying, it's 2 o'clock, I'm supposed to have X? Or are they capable of actually going to the pill box and taking it? All of those components, based on their age and ability, are components that should be looked at and figured out. But taking a picture of the pills at the time of day and what they look like, and talking about, oh, the pink one's for, your thyroid, and the green one is for, whatever else. So also setting a timer is a great way for beginning the youth to think about that. I also encourage families to talk out loud. Gee, I think I need water because my mouth's dry, or gee, my back hurts, I need to sit down. Listening to your body is something that is a learned skill. It's not an acquired, it's a learned acquired skill, but it doesn't come naturally. So helping families to talk about it that way and saying, it's okay for you to say, I'm really tired today and I need to go to bed earlier. When we talk about emergency planning, we often talk about, that big emergency planning, but we don't talk about the day-to-day. And in transition for school, we often talk about going to your local firehouse and having them explain their health care need to the fire people, and I can't think of the name right now, but you know what I mean, and explaining, I live at this address and this is what I need and blah, blah, blah. But role-playing an emergency, families often will role-play fire, evacuation, etc., but talking about what that emergency room use is and when you would need it and when you don't. All of those components are things that are critical. The other thing to think about is that families, as they let the kiddo grow, their world becomes more centered around friends, etc., which is a great and healthy way. If the child does have any kind of special health care need, making friends aware of that is pretty important. So, just having a sheet or whatever, it may be real lame according to the kid, but it will put mom and dad's mind at ease, or grandma or whoever is kind of in charge as to, oh, that kid does know that, Sadie's allergic to peanuts and, not to have a peanut butter parfait at Dairy Queen. Anyway, bad example, but you got it. It's question time again. I'm sitting on that box.
That's a good thing because you've got some questions that came in.
Yay!
Yay! First from Joanna. She was wondering if there are any resources available to help organizations offset the cost for getting transition wheels.
I believe there is, but I need to look into that. There are a couple of organizations that will help. Is she from a provider office?
Care manager.
Okay. So, and then I don't know if she's in a large group, if they're going to buy in bulk or anything like that. But I will look into that, and you'll have to help me figure out how to best communicate that back.
Not a problem. And we also have another question from Julie. She was wondering if you have any tools for health documentation, such as personal health records. This could be useful for both kids and parents to have something an older child could take some responsibility for maintaining or updating.
Yes, there are many. If you go to a pharmacy, you can actually buy, if you have discretionary funds, a bracelet or it's a USB drive that actually has everything in there. Microsoft has a free one that you can download. That's a health, I think it's called the Vault, Health Vault, something like that. And then at the end of this presentation, there are some resources, and one is a checklist, a transition checklist. But if you Google health history or documentation, you will pull up more than you ever wanted. And I encourage you to do so. So all of that is great questions.
I've got one more from Ashley. She was wondering if you could speak to the resources available to assist adults with special health care needs to transition from their parents' home and parents' care to community living.
Yes, and it's actually there's some funding coming out of Medicaid that's moving people from nursing homes, but there's also funding in working around getting people into the community. So their first step would be either their community center board, their single entry point. So I've given you those two resources, as well as you'd get information from the ARCs if there's a cognitive deficit. And let me think. And if they're in a managed care entity, there are care managers that could do that. And care managers, stop rolling your eyes. I can just feel them rolling. But I would start there. That's where I would start. And also having those parents talk to other families who have done it or in the process of doing it, because there's it takes some time and energy.
Well, that's great, and that is our questions for this particular time. We have one more question and answer session at the very end of this webinar, so keep your questions coming, and Christy, I'm going to hand it back to you.
Okie doke. Thank you. So at age 14, we talk about awareness. So we're talking about carrying the copy of the medical card, beginning to understand your needs, making appointments, taking some ownership around like food choices, things like that, and really beginning to discuss the awareness of goals, interests, etc. Then at 16, we're talking about exploration. Again, carrying the medical card, but also understanding the needs. See, there's some overlap. Did you get this? Making appointments, beginning that to take the ownership, and also the goal. So 14 to 16, there's not a lot of change, but boy, is there a lot of learning, and you should see at 14 less initiative, and by 16 a little more initiative. At 18, we're no longer looking at that family income, and the youth may be on supplemental security income if disabled, and that does come with Medicaid. And you would start by going to your Colorado Social Security office, and that link is at the bottom of this slide. At 21, some things change. We've got no more EPSDT so under the child's benefit package. So the dental benefits become reduced. There's no more additional home health care hours, and there's some special screenings that go away. So that changes pretty significantly. But at age 21, we are now fully adults, and there's a lot of other things that need to be looked at. But understanding our health history is pretty critical, especially if we know that we have something that is an underlying or we're a carrier, or something that's going on that we should be aware of in choosing careers, etc. Guardianship is one thing that's very misunderstood, and I'm giving you the information for the Guardianship Alliance and the ARC of Colorado. They, some of the county ARCs do training on guardianship. First of all, I'm not an attorney and I don't play one on TV. I've supported families for years with a simple rule of thumb, that if the youth doesn't understand the financial impact of buying something from a solicitor, whether it's at the door or on the phone, some sort of guardianship should be considered. And guardianship is the big overarching, that is the oversight of all the well-being, maintenance, care, support, comfort of the individual. There are other pieces to guardianship, but we talk about it as guardianship. It's really, there's conservatorship, which is just the financial affairs. There's other components like medical power of attorney, financial power of attorney, CPR directives. We also call those end-of-life directives, proxy decision-making, and beneficiary agreements. But I really encourage families to be suspicious of attorneys selling products, but that getting legal answers before the child has turned 18 and 21 to make sure that they're making the right decisions and have everything in place. So those two entities are really the folks that are doing that the best in the state of Colorado right now. So beginning steps. We've talked about some of these, and we've talked about, color copying the pills and doing seizure and behavior charts and weight charts, all those kinds of things. There's no magic, except for us to be aware that we need to plan for transition. We also need to become better healthcare consumers. And it's not a sprint. It's a relay race. You need to run alongside of the kiddo and still carry the baton and really encourage them along the way. But in order to make that transition a success, we really do need to plan for it. And in planning, really encourage you to suggest that families get a bigger community or reach out to the community. Encourage families not to head into transition alone. It can be felt responsive as a very lonely time for families because they just see the kid getting older and are scared because they're seeing their longevity as well. And asking families to get other people from their community, from their church, religious community, from their family members, whoever has been supportive, and to discuss creating a circle of support, which is what the title of the model is called, a circle of support. And it's a concept that allows families or individuals to come together and to talk about decisions and goal making and planning for the future and what the kiddo wants to do. So the lady that had the question about, how do you do this? Well, starting with a circle of support is a really good way for the family to start with a community support and to build the necessary steps to succeed in getting a kiddo to the community living. So we're asking families and providers to do so much, but in collaboration, it's just the best way to go. And utilizing the skills of the agencies in your area. So we've talked about Family Support or Family Voices Colorado. We've talked about the ARCs, which are funded through the thrift stores in Colorado. We've talked about Parent to Parent. We've talked about the Legal Center and legal services that are available. All of these are on slides at the end of this PowerPoint. Title V, we talked about that with the HCP program, and knowing that the families have insights but often don't all have all the tools that they need. And so we really encourage you to go to that National Healthcare Transition Center. There's the transition checklist. There's one out of Minnesota, the Wasteman Center. And we also have one that was created by Dr. Laura Pickler here in Colorado. So all of these resources are great resources to be utilizing or to be checking into. The final thing is the Guardianship Alliance, the Legal Center, which are the legal resources in the state of Colorado, understanding that the county may provide programming, energy assistance, food, stamps, etc., and where to start with Social Security. So those are all the resources available to you for this population. There's the website and the link, and we're to questions.
Well, since it's 1:01, I want to respect everyone's time. So if you have questions, you can still put them in the chat box, and we will create a frequently asked questions document and email them out to you. Within 2 weeks of this webinar, we'll have a video of this webinar as well as the slides that you can download from our website, VC3. So on behalf of Family Voices, Colorado Access, and everyone involved in this webinar, I thank you for your time.